All right. So we are live. Thank you so much uh, for being patient with us. We had some technical difficulties, but we're here and we are ready to start our conversation. But before we start our conversation, I am going to introduce our panelists, and it's quite an amazing panel. So I will start with Dr. Khadija Brathus. So Dr. Brathus is an assistant professor at UA College of Medicine. So in the Tuscan, so the division, or the University of Arizona College of Medicine. So she's in the division of cardiology. She's a member of the University of Arizona Sarver Heart Center and a heart failure specialist with the advanced heart failure, mechanical circulatory support, and cardiac transplantation team at Banner University Medical Center, Tucson. She's a board certified. She's board certified in internal medicine, cardiology, and advanced heart failure and transplant cardiology. In 2018, she was also named a fellow of the American College of Cardiology, American Heart Association, and Heart Failure Society of America. Dr. Brathus' clinical interests include heart failure, cardiac transplantation, mechanical circulatory devices, and women's health. So welcome, Dr. Brathus.
Thank you.
Our second speaker is Dr. Colwyn Hadley. He is a first-year postdoc fellow in the Cardiovascular Institute at Stanford University School of Medicine. At Stanford's Cardiovascular Institute in the lab of Philip Tsao, Dr. Hadley is combining his interest in immunology, mitochondrial biology, and aging to deeper investigate the aging-associated shifts within the immunocardiometabolic axis and how these may favor cardiovascular disease progression. Before starting his fellowship at Stanford, Dr. Hadley was also involved in several research projects at the Texas Biomedical Research Institute related to host pathogen interactions and infectious diseases, including Mycobacterium tuberculosis, influenza A, and SARS-CoV-2, which leads to COVID-19. So welcome, Dr. Hadley.
Pleasure to be here.
So our other speaker is Dreven Dobson. Mr. Dreven Dobson is a PhD student in the pathobiology and translational is a PhD student in pathobiology and translational biology, if I'm not wrong, in the PhD program at UNC Chapel Hill. So Dr. Dreven Dobson works in the Blood Research Center in the Wahlberg Lab with Alisa Warburg, who is an amazing scientist. And he studies genes that regulate fibrinogen expression. So welcome, Mr. Dobson.
Thanks, happy to be here.
So our last speaker is Bumi Ogunbe, and she's a PhD student at Johns Hopkins School of Nursing. So her research at the School of Nursing focuses on assessing cardiovascular disease risks among African immigrants. So welcome, Ms. Ogunbe.
Thank you very much.
So let's start our conversation. So today, obviously, all of you have these extraordinary research backgrounds. So my first question will be to ask you in 2 to 3 minutes, could you talk a little bit about your work and how you incorporate COVID-19 or how it is related to COVID-19? So I'll start with Dreven. So tell us a little bit about your work and how it is related to COVID-19.
Sure. So our lab has, over the pandemic, started to study COVID-19 and its relationship to COVID-19 associated thrombosis. So we've recently published a study that took the plasmas from COVID patients and compared them to the plasmas of sepsis patients to see how their procoagulant activity was different, and whether we could identify any proteins that were measurable that could make COVID-19 patients more susceptible to thrombosis. And as you mentioned in my introduction, I studied fibrinogen and the genetic factors that influence its expression. And what we found is that fibrinogen is one of the proteins that is highly elevated in COVID-19 patient plasmas. And other labs and studies have found that it's actually a good prognostic biomarker in terms of measuring fibrinogen levels in COVID patients as to who is more susceptible to more detrimental end stages of the disease, like acute respiratory distress syndrome. So that's essentially how my work is related. It just so happens that I was studying fibrinogen when the pandemic started, and fibrinogen has actually been very implicated in the pathogenesis of COVID-19.
Definitely. Thank you so much for sharing that. We kind of share similar circles because my work is also on thromboinflammatory biomarkers, and I just published a paper on the association between some of these biomarkers and D-dimer. So that's very interesting to hear your work on thrombosis, and because thrombosis and all these thromboinflammatory biomarkers, they play an important role in a host of cardiovascular diseases and COVID-19. So you can definitely say the link between cardiovascular conditions and COVID-19 when it comes to these thrombotic or thromboinflammatory biomarkers. So I am going to go to ask Dr. Bertha to share her work and how it is related to COVID-19 or incorporate COVID-19.
Sure, and thank you for having me here again. So my name is Dr. Bretta, and I'm a heart failure transplant cardiologist as well as a physician scientist, where my work focuses on reducing racial and ethnic gender disparities in heart failure. And so COVID-19 is really all-encompassing, given that I take care of kind of the sickest of the sick population, which is at the highest risk for developing this disease. And it's changed the way that we practice and that we provide clinical care. Well, personally, I've transitioned to almost entirely remote care for outpatient visits using telemedicine, so that patients can safely receive the care that they need without delaying or fear of pushing it off or not having it at all. And so it's been very helpful to make sure that patients get the proper high quality care that they need, because a lot of this can be done virtually. I'd say that it's eliminated some of the problems with lack of access to different forms of digital forms of therapy, and for patients that may not have access to broadband types of internet, which is a major issue that needs to be addressed from both the state as well as the federal level if we're going to improve that. And as far as the disparities and the desire for achieving equity in heart failure, we've seen with COVID-19 and with our era for social justice that we have a long way to go, and some of the systematic problems that exist within the policies of how our patients are cared for and within the way our healthcare system is structured is set up for our patients to fail. And we have to address them from a critical eye to see how we can make sure that bias, that racism, that social determinants of health do not remain a consistent factor in whether or not they live or die.
Definitely. Thank you so much for sharing that. That's important piece of information, because things have shifted, and I think what also has not shifted, but has become clearer is our understanding of these social and structural factors and how they do influence who is at risk who can get infected and who is at risk for developing the more severe form of COVID-19, and also potentially, and that's why we need more research, who is at risk of developing long COVID. So speaking of these factors, I'm going to switch to Ms. Ogunbe. So she's going to tell us a little bit about her work and also how it is related or has incorporated COVID-19.
Thank you, Deborah. It's lovely to be here. And I am a cardiovascular epidemiologist, and what I currently do as far as COVID-19 is concerned is to assess biomarkers of myocardial injury and inflammation in non-hospitalized patients. So one could argue that we probably know enough, and in some cases more than enough, about hospitalized patients and cardiovascular consequences of COVID-19 in that population. But what I am currently doing is looking at people who were never hospitalized, who some people would refer to their symptoms as mild to moderate, even though that's a term that has been recommended that we not necessarily use to describe this population. And so what I'm basically doing is assess if there is any evidence of ongoing myocardial injury and inflammation in this population. Now, it doesn't just stop there. This also includes cardiac-related post-acute sequela of COVID-19, so specifically looking at those phenotypes that are very specific to the cardiovascular system and trying to characterize this a little bit more. Another thing where I'm also currently involved with as part of this other big project is to also collect experiential experiences. So we're looking at people, experiential accounts. So people who have underlying cardiovascular disease and also had COVID-19 at some point. We are collecting accounts of what their experiences were, what their symptoms are, and what they currently also experience in terms of long COVID or post-acute sequela of COVID. One other project that I work on, which is also COVID-19 related, is with the Johns Hopkins Institute for Clinical and Translational Science research, we developed a COVID-19 recruitment registry. The goal is initially and still the goal is to ensure equitable recruitment of participants into research studies that are very specific to COVID-19.
Thank you so much. So your work is very wide, looking at these non-hospitalized or mild COVID-19 patients, and also you are dabbing into this more looking at long COVID, people with long COVID and how and some of these cardiovascular symptoms. So this is going to be a great conversation. It's probably we're going to go back to you because I recently shared on Twitter, like just wanted to talk a little bit about COVID-19, long COVID and the understanding of long COVID. And a lot of people don't know what it is. And a lot of people don't know that there are long-term potentially long-term consequences to being infected with COVID-19. So that is a conversation potential that we will, if we have time, we will try to have. So I'm going to move to our final speaker, Dr. Colin Headley. So Dr. Headley, could you share a little bit about your work and how it is related or incorporates COVID-19?
Yeah, so right now I'm doing a postdoctoral fellowship in the Cardiovascular Institute here at Stanford. And right before moving out here, I was at Texas Biomedical Research Institute. And so I wrapped up my dissertation, which is primarily related to mycobacterial tuberculosis. It's a BSL-3 pathogen. And so when COVID hit, everyone that was working on TB sort of shifted to working on COVID. And so that's where I got that's how I jumped into, I guess, into the battle, if you want to call it that. And I was involved, I was part of the team part of one of the early groups to validate the transgenic mouse model that's now commonly used to study the disease. And a second project I was involved with is is characterizing monoclonal antibody therapies for areas that are not high on, not privy to vaccines just yet. So.
Yes, thank you so much. Thank you so much for sharing your work, and it's very great that we have you here, because having that mouse model, and for those of us who, for people in our audience who don't necessarily understand what mouse models do, but they are very important in allowing us to understand diseases and potentially also developing some of the treatments that we need to have when it comes to for those diseases. So having that for COVID-19 has been tremendous, and it has been very important. So I'm going to move to my next question. So can you tell us a little bit about the link between the cardiovascular health and COVID-19 infection and severity? So I will ask Dr. Brathus. So what is the link between cardiovascular health and COVID-19 infections / severity?
So there are multiple. First and foremost is those that have cardiovascular disease are higher risk for bad outcomes if they get COVID-19, which is why we stress over and over for patients to please consider getting the COVID vaccine. And if you already have it, to get the booster. There's so much disinformation out there and misinformation. It's hard to know who to trust. Trust your physician. Reach out to them, reach out to any of us to ask questions so that we can hopefully answer them, so that you can see the benefit that you get from this. As we all can tell, there are new variants out there for COVID-19 that are making it the transmission of this disease higher. And so the best form of protection, again, remains the vaccine plus wearing a mask. So number one, higher risk of comorbidities, and especially if you're a heart transplant patient or on any type of immunocompromising med or immunocompromising situation, you're at higher risk. Number two, we have patients that are fearful of going to the hospital or fearful of being seen. And we have already seen in multiple studies that the risk of dying from cardiovascular disease is on the uprise, higher than what it should be, and excess mortality. And that's related to not getting care or not being able to get care when you go to the hospital, because the hospital is full because of COVID-19. And so the biggest, I guess, the greatest message in terms of doing your part is to get vaccinated, wear a mask, and if you have problems, see your doctor, call them, ask if telemedicine is an option. And most certainly for emergencies, please still call 911, please still go to the hospital. Don't die alone or die at home for something that's potentially preventable.
Definitely. Thank you so much for this very important advice when it comes to cardiovascular health and just the being at a higher risk for COVID-19, which I've stressed out with a couple of members of my own family, that if you have hypertension and you have some of these cardiovascular conditions, then your risk is higher. So definitely think about all these protective measures, such as wearing a mask, and all these different things, especially getting your vaccine. So I'm going to move to Miss Ogunbe. So can you tell us a little bit what you know about the link between cardiovascular health and COVID-19 infection and severity?
Sure, I'll be happy to, and I'll try my possible best to now repeat what Dr. Bertha already mentioned. I think I'll speak more to what the consequences are, both for people who may have underlying cardiovascular disease and people who may not have previously been diagnosed with any cardiovascular disease, but then may have symptoms or even diagnosed complications after COVID-19 diagnosis. So we do know that COVID-19 starts typically as a respiratory disease, but then other major organs, including the heart and the vessels, are affected. And this is, there are a lot of underlying subclinical mechanisms and explanations for this. But as far as what we see and what has been reported clinically, there are people who, for some reason, for reasons that maybe not some reasons that we know, are being diagnosed with acute cardiac injury, with cardiomyopathy, people having all kinds of arrhythmias, hemodynamic instability, troponin release is also a very common one, and release of other cardiac biomarkers that are indicative of myocarditis or ongoing cardiac injury. And just epidemiologically, this has been reported in studies over and over again. One of the studies that I've read in the past few months has reported that people who have had COVID-19 comparing people with underlying cardiovascular disease and those without underlying cardiovascular disease. People with underlying cardiovascular disease who then had COVID are more likely to experience worse outcomes, 3 times more likely, actually, this study reported, to have worse outcomes than persons who didn't have underlying cardiovascular disease. So I guess I'm speaking to sort of like the bidirectionality happening here, which is people who have underlying disease and then who got COVID more likely to have worse outcomes. And then we are also seeing people who may not necessarily have an existing CVD diagnosis, but then also reporting persistent symptoms that may be indicative of some ongoing cardiac injury.
So, which we've talked about these consequences when it comes to COVID-19 for people with or without underlying conditions. And we've mentioned vaccines, and which has been, and we have had very important conversations about vaccines in the United States and outside of the United States. So I'll switch gears a little bit and we'll talk about vaccines. So my first question is, there have been a lot of talks, at times misinformation, disinformation about COVID-19 vaccines and heart conditions like myocarditis, so heart inflammation. So what can you say about that? So Dr. Brathus or Dr. Headley?
Let the physician go first.
Yes.
He was the more patient.
Sure. So some people try to justify not getting the vaccine out of concern. I already have a heart condition. I don't want to make things worse. So in the past week, just in the New England Journal of Medicine, there were a couple of papers and editorial that came out looking at the risk of myocarditis after getting vaccine. And it was about 2 in 100,000 with getting the vaccine. And it's not necessarily related to the vaccine, because we also know just in regular common day, outside of the vaccine, a person may develop myocarditis for a reason that's unknown, which is often the case. Now, compare just a person that gets COVID and their risk of getting myocarditis in the setting of having the COVID virus. It's about 150 per 100,000. So we're saying 150 per 100,000 versus 2 in 100,000. I think that's clearly showing that your risk is much greater of getting myocarditis with getting COVID. And your risk of getting COVID is incredibly high. And some epidemiologists are suggesting it's just a matter of time until everybody gets COVID, and it's up to you to determine how well protected you're going to be once you are put into contact with COVID. So I strongly urge people to consider getting the vaccine plus the booster, plus wearing a mask until we have global access to this vaccine, because this is a global issue and we live in a society that is able to move things around across the world fairly rapidly.
Definitely. Thank you so much. Dr. Headley?
I'll follow up with that by saying, I mean, that's exactly the thing. And there's just so much misinformation globally, but also within the Black community. I think there's hesitancy, and sort of like distrust with the medical community. And us as scientists and physicians, we sort of have to mitigate and be that third person to voice the reason. So I remember earlier in the pandemic, I visited a barber shop back in San Antonio, and I told them I was working on, I was helping out with the characterizing the mouse model for COVID, and Texas Biomed was working on the Pfizer vaccine as well. And I remember one of the barbers saying, "Yo, I heard it messes with your nuts." I was like, what? That's not true. And so I think it's important for us as because we're scientists, but we're also Black, and because there's this distrust for medicine, we have to be that voice of reason, and people pretty much talk people off the ledge of not getting the vaccine. And I remember going back 2 months later to get another haircut, and 3 out of the 5 barbers had caught COVID, and one of them were dealing with the consequences of the long-term symptoms of long COVID. And I was like, I told you, I mean, like, you should have gotten it, but I hate being that person and saying I told you so. Rather, trust me and listen. Because I did a whole PhD on immunology, and I'm not lying to you, but I think that's the major issue with science, hard science, and then the communities, like, find that middle ground for communication and effective communication. So,
thank you, thank you so much about this conversation around COVID-19 misinformation, disinformation. There have been a lot of talks about that, especially since science itself is not very open. We have the way that science is done. The scientific process is something that is taught that is not very democratic in a sense, because only a few of us can understand what is happening. Only a few of us can understand how to interpret these results. Because as you see some of these studies, you have to be able to understand what they mean. You also have to be able to understand some of the limitations and put that into a context. And that, I think, is one of the things that we have to do in this period of time, is to be also science communicators, because we have to be able to translate the science in a language that is understandable. But at the same time, we also have to push to make the scientific process a little bit more accessible, or more accessible, because people have to be able to read a paper, or to understand a paper, or to understand the science, and to make informed decisions. So we are still talking about the vaccines. So I'm going to go to Mr. Dobson. My next question is, what other advice would you give to people who are hesitant about getting vaccinated?
I would just second, the things that have already been said about talking to your physician and wearing a mask and protecting yourself. But one thing that has kind of gotten a little bit better since the start of the pandemic is trying to do kind of like Dr. Headley said, which is, breaking down really complicated or complex seeming scientific literature into ways that the average layperson can understand and potentially find comfort in. I know I've had to do that for family members and friends. Every time you bring up the COVID vaccine, oh, they're going to inject me with COVID. Oh, there's a microchip in it. Oh, there's some 5G thing going on. And it's like, okay, let's break this down into, what is an mRNA? What is an mRNA vaccine? When they give it to you, what is it going to do? And sometimes I find shining a little light on that process, where it's not just a black box, can be very helpful in terms of bringing people around. Even if even if it feels like an oversimplification. My go-to is breaking it down into simple everyday language as close as possible to the actual biological process. In terms of the vaccine is just giving the cells in your body information that says, hey, this is what COVID looks like. So when it shows up, you recognize it and you're good to go and you don't have a problem. And even something just that simple, I find can be helpful, as well as directing them to their own resources. It's like, hey, you don't have to just trust me alone. The CDC has a nice little blurb on the vaccine and what's in it, what it's doing. So things like that, having numbers for people, kind of like Dr. Bertha did in terms of the stats of vaccinated versus not vaccinated. Any of those things can be helpful in terms of getting everyone, especially people in the Black community, on board to protect ourselves before we have to deal with some of these long-lasting complications.
Definitely. Thank you so much for mentioning that. So I want to stop a little bit and ask and tell our audience. So if you have questions, if you are on Zoom, you can use the Q&A to ask your questions. If you are on Twitter or YouTube, definitely send us your questions. I know that there is a lot of interest in this topic. So these are experts and they can definitely help answer some of your more pressing questions about COVID-19, the vaccines and long COVID. So we are going to switch gears and not necessarily switch gears, but let's talk about the Omicron variant, which is something that has happened, and we are seeing this, that sadly the preliminary data, which is becoming more and more convincing, is showing that it is more infectious than previous variants of SARS-CoV-2. So let's talk about the Omicron variant and the vaccine and vaccine inequity. So there are glaring racial and geographic disparities in vaccine administration. So for instance, less than 5% of people on the African continent are vaccinated. Why do you think it is important to have global vaccine equity? And what does global vaccine inequity teach us about disparities in cardiovascular diseases, especially when it comes to hypertension, because hypertension is the big thing when it comes to cardiovascular conditions in Black communities of the diaspora. So the first question is, what do you think, having in light of the Omicron variant, what do you think it is important to have vaccine equity? And the second question is, what does it teach us, that vaccine inequity, what does it teach us about cardiovascular disparities, especially for conditions like hypertension? So I will start with Mrs. Ogunbe. So please go ahead and tell us a little bit what you think about these two questions.
Yes, absolutely. I will share my thoughts. We do know that the COVID-19 virus is an mRNA virus, is an RNA virus, sorry. And so it's just the nature of RNA virus to mutate. And as long as we keep this virus around, unfortunately, we may continue to have variants because the virus is basically trying to survive. And that's why vaccine equity is important, because we need to make sure we get to a point where a substantial proportion of the global population have received the vaccine. And in that way, we are able to hopefully quickly phase out this virus, at least in human hosts. So that's the whole point. As long as we're able to get a lot of people, more people vaccinated, we're quickly, the quickly we'll be able to hopefully be out of this. I do know there are a lot of varying opinions about this, and people think this is going to be around for so long, but the basic idea is that as long as we have the virus in humans, mutation will continue to happen, and then we continue to have these new variants, and some of them, as we have seen with Delta, I know the data is still coming together for Omicron, but for Delta, we did see that it's a lot more highly infectious, and people who contracted the Delta variant had worse outcomes than the variants we had seen before. So essentially, as far as vaccine equity is concerned, it's very important that we get the vaccines to the rest, to everywhere in the world, not just on the continent of Africa. There's also Southeast Asia. There are other regions where vaccine equity isn't just where vaccinated proportion of people who are vaccinated isn't optimal at all. And so it's important that we do this. I think more than anything, this pandemic has really shown us how interrelated we are, and that it's truly a global village. And clearly, whatever is affecting a person in point X, could also be affecting another person who lives in point B, clearly with this virus. So I think my message would be that we continue to advocate for this. We continue to call on agencies and people who are making these decisions to ensure that everyone everywhere gets the vaccine. The other question, hypertension disparities. So yes, I can definitely see the parallel, because yes, I do some hypertension related research as well. And I understand that some strategies, some hypertension control, blood pressure control strategies, or strategies that has been employed in some regions to improve hypertension outcomes or blood pressure outcomes and prevent cardiovascular disease, as not being properly adopted in other regions, or even properly translated to other regions. And so, yes, that's a problem as well in terms of disparities in how we have addressed hypertension, and in the strategies we have employed so far to address hypertension. So yes, that's also something. Just as we're advocating for vaccine equity, we should also be advocating, in this case, for hypertension control strategies, blood pressure control strategies that are appropriate, that are contextually appropriate to places where we are beginning to see higher prevalence of hypertension and other cardiovascular risk factors.
I'm sorry. Thank you so much for this insight in vaccine equity and hypertension disparities, because there are definite parallels when it comes to what is happening, some of the disparities that we see in these infectious diseases, and other disparities we see in more chronic conditions. So which highlights a very structural and social issues that we have to start dealing with, because it is not right that some people have to suffer more compared to others, because health is a human right. So we should all have an equal opportunity to good health. So I'm going to move to Dr. Headley. Can you tell us a little bit about just how why do you think it is important to have global vaccine equity, and what are the parallels between global vaccine inequity and some of the disparities, like racial, geographic disparities we see in cardiovascular conditions like hypertension?
Sorry, I feel like my net might be acting a fool a little bit. But so the question was my thoughts on vaccine inequities and pretty much cardiovascular, the difference in cardiovascular disease and pretty much, I was saying, Black community. So for one, African Americans are predisposed to cardiovascular dysfunctions, and I believe heart disease is the number one killer of African Americans. In general, cardiovascular disease is the number one killer globally. So that's one thing we need to address is how do we talk to the community about what we eat and how do we maintain health long term? Because again, I go to the barbershop a lot, but I was talking to the barber again about our habits as far as like from high school through college. Just like we're much more active, and as we get older, our activity level wanes. But we're big on soul food, and soul food's not bad, but there needs to be a balance. You need to know, if you're going to eat, stuff that you love, then you also have to work off that extra energy. I think that's important. It's finding the right balance. So that's one thing. As far as like vaccine inequity, viruses will mutate. That's just what happens. And so the longer a virus is within a population, and if it's left unchecked, then it's going to keep mutating. And so I'm not going to be surprised if in another 3 months you're going to figure out there's another COVID sorority, sorority sister. It's Omicron now, it's going to be Tau or something later. That's just the reality of the situation. So it's extremely important that we provide vaccines to everyone on a global scale, because that's the only way to eliminate a pathogen. That's just the reality of it.
Thank you so much for your insight. So we have a question. So how has what do you think, or how has the involvement of Black scientists and physicians improved our knowledge and treatment of COVID-19? So I'll start with Mr. Dobson. So how has the involvement of Black scientists and physicians improved our knowledge and treatment of COVID-19?
I think Black scientists have really been leading the charge here. I mean, a great example that comes to mind is Dr. Kizzmekia Corbett, who was really in charge of spearheading the development of the Moderna vaccine. And I'm so happy to see her getting her flowers in terms of an appreciation in the work that she's been doing, along with other great scientists who've been kind of working on potential solutions. And even just the results of that, from seeing little Black girls on social media saying they want to be a scientist when they grow up, to her ability to go talk to Black churches and go into the Black community and gain the trust of community members to kind of get people vaccinated. I think it's a huge example of how and why representation matters, and kind of showing the hard work that Black scientists are doing is really helping us make strides. And I think as we continue to do more, it will continue to be helpful. And it's definitely inspired me to tell more people about what I do and what I study. I think sometimes, even though we're around, we're not always visible. And I think COVID has shown what can happen when we put ourselves out there and are visible and people see themselves in us. So I think it's been great to have Black scientists involved every step of the way.
Definitely. So Dr. Brathus, can you tell us how the involvement of Black physicians has improved what we know about COVID-19 and treatment of COVID-19?
I'd second statements from Dr. Dobson. It's shown the urgent need to diversify our ranks. We know that talent is everywhere, but diverse populations really get those opportunities and are really sponsored to reach the heights that they're able to ascend to, as far as providing clinical care, doing research, leading community change. I've been incredibly encouraged by the scientists, physicians, physician scientists, healthcare professionals of color who've been doing really hard work over this time period to not only advance the science, but to keep our community up to date by providing talks, community talks, by providing vaccinations, by being available to answer questions from families, friends, and other community members. And it just shows the value of diversity and uplifting the cause to diversify our ranks, to have more scientists, to have more healthcare professionals, because we bring something special. We bring a certain experience of these issues and an ability to talk to our communities in a way that they know that we care about them and that they know they can trust us, and vice versa. And that's something really special. And it's going to take some time for that to become more widespread, given that we live in a society that is rampant with racism, with a failing healthcare system and public health infrastructure. I am encouraged, however, with all of these things, that there is going to be change, that our policies, that our structures will change, that we will be given opportunities to lead these goals to make things better and make them work for our communities.
Definitely. So we have another question. How can we switch the mindset of individuality to a more global mindset when it comes to vaccine equity? Countries are only thinking about themselves until there are vaccines everywhere, we aren't going to get out of this pandemic. So how can we change it? So Mrs. Ogunbe?
Yes, I can speak to that a little bit. It's almost a case of what affects me, affects you, and affects all of us. That's currently what we've seen and where we are with this virus and with the pandemic generally. I think almost every sociologist and maybe anthropologist will tell you it's a little difficult to shift societal values or to change some of those beliefs or norms of certain societies. It takes time, sometimes years and years. And so to speak to trying to help people understand that while it is valuable to hold an individualistic belief or have that approach towards a lot of things, sometimes it's also important to realize that we don't live in isolation. No one lives on an island by themselves in the society that we currently are in. We are all, we live in a community, essentially, and now these days we live in a global community. And so it's important for us to, yes, continue to have these conversations and explain to people why just scientifically it makes sense that we consider everybody in terms of vaccine equity, in terms of other strategies that are being employed to mitigate the effects of this pandemic, but also that it doesn't just stop here. Just as you've said earlier, there are other diseases, there are other chronic diseases that affect us as a whole. Maybe there could be another infectious disease coming around the corner at some point. Hopefully not, but that could also happen in the future, and that we need to be better prepared. And the way to be better prepared is to think about all of us is living in a global village, and that we are all connected some way. And so we I hope countries would do this, would be willing to share resources, to share knowledge, to share the science, to share vaccine in this case. But to really address that question, yes, it's important for us to continue to push to have this conversation. As far as changing people's opinion or people's beliefs, I don't know that we can do that overnight. It may take a long time for every single person to realize the importance of community and just having that perspective, and how it's sometimes a lot more, could be very effective and efficient even to approach things like this pandemic and other things from sort of a community approach rather than just an individualistic approach.
Definitely. Thank you so much for answering to this question. And no, so we're going to switch gears and talk a little bit about long COVID. A couple of days ago, I asked people if they knew what long COVID was, and I got a lot of responses with regards to long COVID, with regards to people who are going through long COVID and the need for awareness about long COVID, because the lack of awareness that we have when it comes to long COVID is having consequences. One of those consequences is that people are not believed when they share some of these symptoms related to long COVID. So I felt it was very important, as we are having this discussion about COVID-19 and cardiovascular health, to also raise awareness about long COVID. So I am going to ask you, my first question is, can you tell me what you know about long COVID, or the more scientific term is post-acute sequelae of SARS-CoV-2 infection, or PASC? So I will start with Dr. Brathus.
In this area, there is still a lot to be learned, and there are a number of trials that are ongoing to understand what are the full long-term sequela after having the diagnosis of COVID, because frankly, there's a lot we just don't know. For patients that do have a new development of a cardiovascular disease, immediately after, there is a surveillance and follow-up for them. For those that have virtually no symptoms, but then go on to develop cardiovascular complications, there's a way to address and surveil them and find out what is the long-term risk, which we just don't know. And then there's also the population that I think they're calling it like bystander or something like that, where they didn't get COVID, but because they didn't get the care that they needed because of either delays, or they went to the hospital and the hospital wasn't able to provide the appropriate care because of too many COVID patients taking up acute care beds, they had worse outcomes. And all of that population fits under the long COVID, but it's really important to just dissect it down to be as clear as possible. What are the current symptoms? What is the current disease? And what was the profile with developing the COVID, so that we can understand what's the best way to treat them. But we're, as anyone has seen in the past couple of years, are digesting information rapidly, just as you are, and we'll provide information as we get it to help provide you the optimal care. I would say, especially since we already know that patients, particularly of color and female patients, do not receive optimal care and are often doubted. Sometimes previously called, and still is, hysteria for women. And we've seen in the news where women of color have been denied and ignored and died due to it. So I stress that you seek a healthcare professional that listens to you, one that you can trust, so that you can address the concerns that you have. And if you don't have that type of relationship with your current healthcare professional, recommend that you get another one. If you're like, I really want somebody, like I want a Black healthcare professional, there are sites available, like Association of Black Cardiologists, where you can send them your information. They can tell you the nearest Black cardiologist near where you live so that you can get care that way if needed. And I know that there's some other programs, I think within like the National Medical Association to identify Black physicians, I believe. I'm not sure with like nurse practitioners or PAs that are Black or of color of the best mechanism to reach them, and maybe someone's available that can describe that here today. But just don't give up, don't dismiss the odd symptom you're having, get the care that you need, and trust that we're learning this information just as you are, and we'll provide you the most evidence-based information that we can to help provide you optimal care.
Definitely, yes. That's very important when it comes to long COVID. It's the research. We need more research. We need more evidence. We need to know what are some of the risk factors, and then we have to start talking prevention, treatment, and all that, and which is happening, but we hope that it happens faster, because some of the data, or we are very conservative when you say that, but about 1 in 10 of people infected with SARS-CoV-2 might or will develop long-term consequences or complications of COVID-19. Now, the length of those long-term complications does vary, but it's worrisome to see that it's a large portion of the population, and now we have a variant that is very contagious. And as I repeat, or I keep on repeating myself, is that COVID-19 is not only death; it's also those long-term consequences that are sometimes very severe on people, that people just have their lives completely shifted or completely changed because of getting COVID-19. So really important that we start pushing for more awareness and more research so that people will start getting relieved and get the most adequate treatments when it comes to long COVID. So we have like 2 minutes left. My last question is, so in light of long COVID and its effects on cardiovascular health, what message would you give to the general public? So I will go with Dr. Headley, like in 2 to 3 minutes.
I mean, my message is, I think it's consistent with what Dr. Fauci and most of the physicians are saying, most of the scientists are saying: get the vaccine, wear a mask, and be considerate to the general public.
Definitely, thank you. And Mr. Dobson?
I mean, I would second all of that. Definitely get a physician you trust, get some resources you trust, get vaccinated and masked up, and hopefully together we can all get through the end of this.
Dr. Brathus?
So love your neighbor, wear a mask, and get vaccinated.
Thank you so much for this amazing panel on cardiovascular health and COVID-19. It was a pleasure to have all of you here share your expertise, which is very important to have Black people with the expertise share, and the expertise and the knowledge, share it with the community. And so you can watch this session or rewatch this session on Twitter, on our Facebook page, and on our YouTube channel. So thank you, and have a great day. Bye.
It's been a pleasure.
All right.